Hi, good morning, everyone. This is our second session for 2025. We are on 25th of January 2025, meeting live on uh, around the world from social media. Um, Today, we have a very important topic, Laparo hernia surgery, a continuous challenging moving beyond Bassini to Laparo endoscopic repair. To talk about this topic, we have Dr. Mahesh Mishra. He's a senior laparoscopic and general surgeon, Sitaram Bhartiya Institute of Science and Research, New Delhi. He's a senior visiting consultant, Primus Super Specialty Hospital. Dr. Mishra is well known as as a director for AIMS. He has associated with AIMS for good 37 years before laying his office in 31st January 2017. While most of the people know him as a director for AIMS, but his greatest contribution towards the creation and development of AIMS Trauma Center, one of the main point of contact to provide state-of-the-art patient care for all acute injuries patients for those requiring specialized services. He is a man who is truly responsible for establishment of Apex Trauma Center at AIMS from the scratch. His past assignments were Director AIMS, New Delhi, Chief JPN Apex Trauma Center AIMS in 2000 from 2006 to 2017, Professor of Surgery AIMS New Delhi from 1993 to 2017, Head of the Department for Surgery from 1993 to 2013. His area of special interest improving trauma center services in India by capacity building trained human resource, minimal invasive surgery, surgical training and hernia repair, breast cancer, surgical jaundice, minimal invasive adrenal surgeries, pancreas, common bile duct structure. Sir, over to you.
Thank you, Mr. Saurabh, and thank you, Heart Care Foundation of India and this group for giving me this opportunity. I welcome all of you and wish everyone a great and successful and healthy 2025. We have assured in this year with our organization of Mahakumbh at Prayag, which takes place every 144 years. It's an amazing organization, I must say, this year. Many of you must be witnessing videos and a lot of material on social media about that. I am also very keen to visit till before it comes to an end on 26th of February. And also, I would say that India, we are celebrating our 76th or like that, the Republic Day tomorrow. So I give greetings to everyone on this occasion. And the topic which we discussed with Nishita, so this is hernia. Why I chose this topic? Because it's a common surgical disease. And as a student of surgery, we actually start learning surgery with this procedure. Hernia, hydrocele, appendix, gallbladder. So that is why I thought it might interest general audience how this surgery of hernia, groin hernia particularly, has evolved over last 30 years. So if some of you who are surgeons or even not surgeons would recollect that minimal invasive surgery in the current shape and form was introduced by removal of gallbladder laparoscopically in 1985, 1987. And in 85, there was a German surgeon who could do it. And in 87, there were two French surgeons, Mouret and Dubois, and they were responsible for removing the gallbladder using video technology at that time, available at that time, and presenting the video at the SAGES meeting. What is SAGES? It's a Society of American Gastrointestinal Endosurgeons. And since then, uh, the laparoscopic surgery became very popular. In the beginning, the gallbladder, what we call laparoscopic cholecystectomy, gallbladder removal was the only procedure for general surgeons, and then subsequently appendix were two common general surgical procedures which were popular, and very quickly the laparoscopic removal of gallbladder, which is called laparoscopic cholecystectomy, became so popular among surgeons and patients. What I call it, it spread like a wildfire, what you see today in California, in a other sense. And there were instrument manufacturers who would make instruments, and we started with the first generation endovision systems in early 90s. Then came triple chip, where more resolution was possible. And then we came about with now high definition cameras. Again, the light source have been improving consistently. And so I think there have been huge development in this area. And practically today, minimal invasive surgery, what we see today is not only limited to general surgery and GI surgery, gynecology, who were the first ones to use laparoscopy even before general surgeons for tubal ligation. But operative laparoscopy, what we see today, credit goes to the laparoscopic removal of gallbladder, what we call laparoscopic cholecystectomy. And so laparoscopic cholecystectomy became the gold standard sooner than what we anticipated. But if you see, the hernia, groin hernia particularly, could not become popular for quite some time. I would say for a decade after laparoscopic cholecystectomy, although there were surgeons who were making efforts to do the groin hernia also in early 90s and late 90s. So what we know hernia as inguinoscrotal swelling, when it's large, massive, giant hernias, what you see one of the patients here, naturally these are not amenable for laparoscopic removal. In these cases, the open surgery is preferred. Again, it's a large, massive, giant hernias where the minimal invasive surgery would pose a lot of problems. So we still prefer to operate them. Although some of the massive hernias we can now perform laparoscopically also. Now, why I mentioned that Bassini to Liechtenstein and then Bassini to Liechtenstein to laparoendoscopic hernia surgery. Now, as a student of surgery in 1980s, through that decade, this was the most popular repair. We learned it and we practiced it. Our professors, our teachers performed it, and it gave reasonably good results, but there were recurrences, and the recurrence rate for hernia surgery was high, around 10%, 15%. And then there were other tissue repairs, like we called them shoulders, bloodgood, Bisarda, Stopa, but all of them were not as popular as Bassini. And then we started using in 80s. When I joined All India Institute in 1980, actually, we were using mesh repair also, open mesh repair for groin hernia, which is popularly today known as Liechtenstein's repair, where we do the Bassini type of closure of the canal and the deep ring with the non-absorbable suture, and then we put a mesh. So that is called Liechtenstein's repair. Now, in early 90s, after laparoscopic cholecystectomy, surgeons started making effort to operate groin hernia. So it was introduced first what we called trans-abdominal pre-peritoneal repair, that is TAPP, what you see. But there were high recurrence rates in the beginning. And if you see, in one of the journals, very leading journal, England Journal of Medicine, in 2004, there was an article published where they actually highlighted the problems of laparoscopic groin hernia surgery with high recurrence rates, because until then, the techniques were not standardized. But now, today, we see for last almost, I would say, 20 years or more, laparoendoscopic hernia surgery has been standardized. There are two techniques which are popular among surgeons. One is totally extraperitoneal repair, and the other is transabdominal preperitoneal repair. So in one repair, we go extraperitoneally and then dissect the sac and put the mesh, and in other we go inside the peritoneal cavity and then dissect. Same dissection is carried out and we then put the mesh. So it's a mesh is always used now in open as well as in laparoendoscopic hernia surgery. And now another technique which is becoming popular for particularly for the complex hernias, uh, both ventral and groin hernia, called enhanced view totally extraperitoneal repair, or extended view total extraperitoneal repair, which is short form, it is called ETP. So it is also. So why I chose this? Because there are issues with training in laparoendoscopic groin hernia surgery, which has been established now beyond doubt. It gives better results in terms of postoperative pain, in terms of chronic groin pain, in terms of wound infections, mesh infections, but there is a learning curve. And naturally, in the beginning, it is basically we are not familiar with this anatomy. Operative space may be less in the beginning until one learns how to create good space. And there is a possibility of major vascular injury. Howsoever rare that may be, it has been there. So we have to make it safe. And as soon as we do groin hernia laparoscopically, it is considered an advanced lab procedure. And very many surgeons are reluctant to learn, or they have no opportunity to learn laparoendoscopic groin hernia. And that's why if we look at the adoption of laparoendoscopic groin hernia repair, if you look at Europe, about average 30 to 40% uptake, highest in Germany, 60%. In North America, about 30%. So 70% groin hernias are still done open. It may have increased over last couple of years. In Asia, this proportion is very low. In China, India, and other Asian countries, the adoption of laparoendoscopic groin hernia is really slow and mostly done in private sector with well-equipped hospitals. But now gradually it is picking up. So it's an advanced procedure that has been termed as training opportunities are limited. And what we consider at AIMS, and we devised that model, what we called preceptorship, proctorship model, mentor-mentee model, which we used extensively for teaching and learning laparoscopic removal of gallbladder, laparoscopic cholecystectomy. And then also people the surgeons cite the cost as a major disadvantage because the laparoscopic equipment, the mesh is used. But then to my argument for them is that cost, you already have the equipment for laparoscopic cholecystectomy. You don't need too many extra instruments for performing laparoscopic groin hernia surgery. So cost is in our minds. Yes, I agree. Because here we use plain polypropylene mesh, so which is not very expensive. Then there have been some hernia model training models developed. One is Hamilton TEP model, Guildford Mattu TEP hernia model, McGill laparoscopic inguinal hernia simulator, hernia endo trainers, self-designed hernia trainers. And then we developed our AIMS hernia training module, which I'll be telling you about, So Hamilton TEP model is basically, it is for the formal curriculum developed for postgraduate year 4 residents in laparoscopic TEP, repair in combination with CD-ROM and other videotape material. The result of this model was that there was increased acceptance amongst this postgraduates, which was, the acceptance was not there 100%. It was less 45.5% and increased to offer this operation to patients because they are the point of first contact many a times. So Guildford minimal access therapy training unit, TEP hernia model, again, it does not give a tissue feel. It's low cost, and one can only learn certain laparoscopy skills. So it is developed at minimal access therapy unit in Royal Surrey County Hospital in UK. Its advantages claimed were fiberglass model exactly simulating the human pelvis, anatomy, and similar artificially created anatomy on body wall. The anatomy was more accurately produced. It is less expensive. The only disadvantage, as I mentioned, there is no tissue feel, what we have actually in animal model or cadaver. Now, McGill laparoscopic inguinal hernia simulator, again, it represents inguinal anatomy. It permits to perform both TAPP and TEP repairs, what I have described, the two standardized laparoscopic repairs. And one can actually use this model because it has reusable and disposable components which are readily available. Now, residents trained to proficiency on this model showed significantly greater skill improvement than controls when they were helping us in operation theater. Now, hernia endo trainer, these are self-designed trainers. One can make them in. So these trainers are good to develop basic laparoscopic skills, eye-hand coordination, perception of depth, movement of instruments. So there are this degree of movement which takes place, orientation of magnified anatomy. So all these skills are needed for basic laparoscopic surgery and advanced procedures also. It was indigenously converting a cheap endo trainer into hernia trainer, and one can use it for both bilateral groin and incisional hernia, and it can be used for multiple times. But there is no provision in this for extraperitoneal learning, extraperitoneal procedure. It is good for TAPP and what we call ventral hernia, that is intraperitoneal placement of only mesh. Now, there are animal models. This is one of them. Animal tissues can be incorporated into this model, basically. And it requires animal tissue. Live animals are not required because they are expensive, and there are huge animal rights activists who do not want us to use live animals. So then comes the better understanding of dissection and surgical performance in cadaver simulation. It is so now it increased use is being proposed by many centers across the globe, and this is considered this superior to any bench model or animal model or wet tissue model. 2 consecutive laparoscopy seminars, 7 trainees attended cadaveric and 9 porcine laparoscopy sessions, and they were similar in terms of age and previous laparoscopic and urological experience. This study was published some time ago. What they basically said, comparison on trainee perspectives between porcine, which is on pigs, and fresh cadavers, showed high general satisfaction in both the groups and desired for similar another session. So trainees ranked the training on cadavers higher, better understanding of surgical anatomy, more realistic laparoscopic technique, more appropriate understanding of the use of instruments, all the instruments. So Lab training methods in hernia, bench models, we have seen that. They have limited application, box trainers, animal organs. For hernia, they are not applicable as for gallbladder. I'll show you that. And live animals is a huge cost and ethical issues and licensing, particularly in India. Cadavers, again, can be the best model, but their availability has to be ensured. And simulators, virtual simulators only help to learn the laparoscopic ventral hernia repair. So we have seen Hamilton model, Guildford model, McGill model, hernia endo trainer, and then porcine model. We have seen where we can do on this live pig, we can do only transabdominal pre-peritoneal repair. Peritoneum is very thin. Patent processus vaginalis is present, so one can simulate hernia in this live pig animal, but we cannot perform extraperitoneal repair on live animal. And vascular anatomy cord contents are similar. Bladder is intraperitoneal, so that poses some problem in pigs. So human cadavers could be actually the best simulation, but their availability has to be ensured. Elasticity of tissues can be maintained by soft embalming, which is known as a Thiel technique for human cadaver preservation, especially embalmed human cadavers. We have used them, and well-preserved tissue color, consistency, and transparency without bleeding. Both totally extraperitoneal repair as well as transabdominal preperitoneal repair along with incisional hernia repair can be uh, learned on cadaver because it's a human body. That's the close to real, or actually it is real. Field embalmed cadaver training is more realistic than working on animal models. At AIMS, we had this training model at our minimally invasive training center where we were integrating animal tissue for removing the gallbladder from the liver, the pig liver, and which worked very well for teaching and learning the steps of laparoscopic cholecystectomy. But this model here does not support learning the groin hernia, laparoscopic groin hernia. So basically, we have to develop composite different models, dry lab training for basic surgical skills, animal model which can give us TAPP and repair for ventral hernia, in a preceptorship proctorship model, but field cadaveric model can give us what we are looking for. So we developed this 3-day intensive interactive hernia training course where we would take 6 participants per course, limited lecture session on groin hernia anatomy. 80% of the time, these participants spend their time in operation theater and hands-on. So the course structure was operative demonstration and extensive interaction in operation theater, working on this MIC trainer, what I showed you, for learning basic skills, and then lectures and discussion. Then they would also work on lab mentor, which virtual learning, as we have like simulation, like for which pilots sit on to learn flying, and then wet tissue integration. So day one, they would practice suturing and mesh fixation on Tubingen trainer, what I showed you. Day 2 and 3, they will visit operation theater in a preceptorship model where we will teach them how we are doing these 2 repairs. They are not performing, but we are performing and showing them. And again, we'll show them how do we fix the mesh, suture fixation, tack fixation. And then what we advise these participants when they go back in their own setup, they must invite some expert surgeon to operate under supervision. And this is what proctorship is all about. So we conducted these 55 courses, 330 participants, and these participants were from various parts of India and overseas. Australia, Bangladesh, China, Europe, Iran, Iraq, So 12 courses between August 10 and September 210, 72 surgeons, young surgeons, all of them. And each one of them had laparoscopic experience on laparoscopic cholecystectomy for 3.5 years. And then number of procedures they had performed 30. Most common was lap chole naturally, which is a common surgical disease with groin hernia. And some of them had done intraperitoneal only placement of mesh, what we call IPOM for a small ventral hernias, umbilical hernias, etc. All trainees started performing laparoscopic incisional hernia repair. 38% of them said they are able to perform transabdominal preperitoneal repair, TAPP. 42% said they could do the totally extraperitoneal repair of groin hernia, and both the hernia techniques were used by 20%. And those who had been performing reported improvement in their skills and technique. There were no major complication or recurrences because techniques have been standardized now, a good size mesh which is fixed. And what these participants actually gave the feedback that operation theater visit was most useful, even if they were not given hands-on in the operation theater. So we also used cadaver courses. So 4 cadaver courses we did before COVID. Now again, we are starting that at AIMS and other places in the country. 65 surgeons were trained under expert supervision, and they were able to perform TEP, TAPP, and IPOM. Also, the same cadavers could be used for other operations like mobilization of the colon, nephrectomy, splenectomy, Nissen fundoplication. So one cadaver, actually, one can do quite a lot learning by the same equipment and same preserved cadaver. And simulation, it is nearest to the live patient in OR. That is what I am going to show you. Now you see, this is, we are doing, the trainees are doing transabdominal preperitoneal repair of groin hernia, simulating that on a cadaver. You see how beautifully this cadaver is preserved. And you see, except that there is no bleeding, you see the tissues are so supple. The dissection you see, that is pubic symphysis, and the same equipment, and you don't realize that you are not operating in operation theater. So you create that space by incising the peritoneum, and then also one learns mesh placement, which is an issue in the beginning when one learns operating these patients laparoscopically, and then closure of the peritoneum by using the suture, and they can practice suturing, endosuturing also. This is totally extraperitoneal repair, you see, on the cadaver. Again, you see, this is possible by preserving these cadavers with using this soft embalming technique, Thiel technique. One can also defreeze the cadaver and thaw them subsequently, and you can still get good supple tissues. So you see how beautifully this is the vast difference here, this one, and good demonstration of anatomy, good creation of the space, placement of the and orientation of the mesh, and fixation of the mesh, etc., can be beautifully learned on this model. So what we did a clinical observational study where senior consultant who were well experienced in lap inguinal hernia surgery, and then other consultants in laparoscopic skills because they were performing cholecystectomies but not performing groin hernia. And what we experienced that in the beginning, TEP took little bit longer for a junior consultant. TAPP also looked longer, but this difference in time came down in a preceptorship-proctorship model very quickly. And the younger surgeons caught up with the senior surgeon timing very after 12 and 13 cases. So there was no difference in the learning curve between the two techniques. Experienced surgeons able to perform both procedures significantly faster, as we have shown. Difference plateaued out after 11 procedures. So you can see it's not a because the number of cases to achieve proficiency has not been defined uniformly worldwide. Some people say 30 cases, some say 50 cases, some say 250 cases. So I think every center has to devise their own mechanism. The number of procedures depends upon trainees' level of experience. As I mentioned, 30 to 50, but 250 is an unrealistic number. You can never have it. 13 to 15 procedures for pre-existing laparoscopic skills who had learned. Because we have seen with gallbladder, laparoscopic cholecystectomy, the maximum probability of bile duct injury during cholecystectomy, laparoscopic cholecystectomy is in first 13 to 15 cases. Now, we all know that learning curve is important, both for TEP and TAPP. Good training is necessary to carry out either of the techniques. TEP repair take a little bit longer. It has a longer learning curve than TAPP. And we have published this, our experience, learning curve in laparoscopic inguinal hernia repair. And then we have also said that using the moving average method, minimum 13 laparoscopic hernia repairs are required to reach at par the operative time of an experienced surgeon. Again, we published this editorial in this International Journal of Abdominal Wall and Hernia Surgery. Teaching and learning of laparoscopic hernia surgery in India is a challenge. It's a continuing challenge with its problems and possible solutions. This is one of the largest, I would say, globally. It is in Thailand, Chula Minimally Invasive Surgery Center, where they use almost 300 cadavers annually. And it's a beautiful facility for those who would like to use this facility there. We had this hernia summit in 2019 before COVID. We are looking forward another summit very soon. So another thing which is needed, certification and accreditation. We must ensure competence and adequate laparoscopy exposure. So both for international and national level. So there are these fellowships in laparoscopic surgery, endoscopic surgery, and then nationally in India, we have this MCLS, member of College of Laparoscopic Surgeon, fellow of College of Laparoscopic Surgeon. Then there are 3 associations in India which are rolling out these fellowship, FIAGES and FMAS. To ensure continual learning and improvement, we require to assess ongoing competence, and recertification is also important. So what I would say that we have been working on in this area. And if you look at this, so to develop autonomy, it is for 3 cornerstones of successful training, basically. Virtual simulator one can use to familiarize with the anatomy. Dedicated personnel and organization is needed to establish a training facility. And then the learner has to have internal motivation to learn the essential skills in laparoscopic surgery by participating in this to develop autonomy in performance. So we show them how it is done, then he knows how it is done, knows how it can be done, shows how, and then the participant does himself. So that's the curriculum basically. So it is a step-by approach. Again, to highlight the same, that basically it knows means we have to tell them the cognitive domain, which is the anatomy, about the anatomy, and then procedural knowledge, step 2, and then step 3, how it is done, we show them, and then naturally one can perform and practice more. That's how one develop autonomy of performing any skill basically, and for laparoscopy, it is much more needed. So what I would say that best hands-on clinical training, what we need to emphasize on the knowledge component. Skills are very important in surgery, and then attitude to learn and refine the technique. Higher training after obtaining postgraduate qualification in surgery, like in India, we have MS and DNB by National Board. This is a 3-year program. And then after that, there is a higher training, what we call senior residency training. So it provides optimal exposure to acquire knowledge, opportunity to observe, assist, and perform with assistance of a faculty, mentor, mentee. So to residents get that opportunity. For other practicing surgeons, they have to invite an expert to their own center to develop that kind of a model. So objective is that all the surgeons who are trained should develop autonomy and can perform this procedure independently. This is another new journal which has come out, International Journal of Abdominal Wall and Hernia Surgeries. So I am associate editor of this journal. It is under the auspices of International Endo-Hernia Society. These training centers exist in the country, in India. Minimal invasive training center at AIMS. Then CMAAO, which was run by stores in Mumbai. I don't know whether it is still functional because I learned that it has been closed down. There is another Dr. Padma Kumar in Kochi, Varvenden training facility, and there one can get a hands-on on the patient also. He allows the visiting surgeons who have registered with him for longer period. Another hospital is the Sachkhand Hospital, Agra, and there are other centers also providing this kind of a training. So what I would say, how the journey has moved from Bassini to which was largely a tissue repair, then other tissue repairs, then we moved to mesh repair, open mesh repair, and now we have moved to Laparo endoscopic hernia repair, which is training. I can say that it is effective in teaching and learning laparoscopic endoscopic hernia operation, and repetitive and focused training reduces learning curve and also avoids complications. Preceptorship and proctorship model, which worked for removing gallbladder laparoscopically, can also work beautifully for hernia surgery. So we would like to emphasize that cadaver training, if one can organize and can get hands-on on that, that's the best what I consider. So I thank you once again, Mr. Saurabh, and for giving me this opportunity today for this webinar.
Thank you, Dr. Mishra. I think wonderful presentation.
I would be happy to take if there are any questions.
Sure.
Thank you, Dr. Saurabh. Mr. Saurabh, can I ask the question?
Please go ahead. So can you please close the
Thank-
presentation so that we can
Thank you.
take the
Thank
floor?
you,
I will
Dr.
just
Mishra, Professor Mishra. Thank you so much providing very beautiful information, and almost this problem is everywhere, and everywhere one can see this one. Can you briefly let me know only one question? What are the different precautions that one should not suffer this disease?
precautions for
Getting the hernia.
you mean prevention of hernia
Yes,
happening?
yes, prevention.
That prevention can be taken, Dr. Bukhari, only for incisional hernia. Groin hernia, there is no precaution which we can take on our part. It is some in young people, very young people, we see in children, this is a congenital hernia. Then we see in young adults, the processus vaginalis, which was supposed to be obliterated at birth, does not get obliterated and it goes on to develop an hernia in young age and middle age. And then also we see even in elderly, we see indirect hernia. But towards my age, the hernia is more direct hernias, basically. So, and that is just because of the muscle weakness. Because we all know that at age we lose our muscle mass, and we do get these direct hernias, mostly bilateral hernias in elderly population. So groin hernia prevention is just not possible. But for incisional hernia, if we use the appropriate suture material, if we do not allow the wound get infected, one can avoid many of these hernias, incisional hernias after laparotomy. But with the advent of laparoscopy, now the incidence of laparotomy also has gone down. Previously, we were doing open gallbladder surgery and there were incisional hernias through those incisions also. Similarly, kidney stone was a very common operation, openly done. But nowadays, most kidney stones can be managed laparoendoscopically, either PCNL or endourology through bladder and ureter. You pass the small endoscope and stones can be removed, and lithotripsy. And also, while using percutaneous nephrolithotomy, they take the laser and crush the stone. So this endoscopic techniques, what we call natural orifice techniques, have evolved. In laparoscopic surgery, the natural orifice surgery, what I can say, like you have vaginal hysterectomy, no incision on the abdomen. We developed in research the transvaginal cholecystectomy, laparoscopic cholecystectomy. And actually we had the instruments, we performed some of them, but then with single port came in and robotics came in. So people lost interest in that because what these natural orifice surgery, some people were recommending transgastric, transcolonic, which are actually fraught with consequences. So that cannot become popular. So the only natural orifice, I would say, either the urologic procedures, which they do endoscopically, or the non-descent vaginal hysterectomy. And one can also use posterior fornix access to do other procedures. There is a possibility, provided people are interested to develop that.
Thank you so much, Dr. Mishra. Thank you so much. Very nice.
One question here, Dr. Mishra. What is the role of robotic surgery in this hernial repair?
Particularly with hernia.
With hernia, yeah.
Yeah. If my take is that robotics for groin hernia is like killing a fly with a gun. It's really not needed, except in some complex hernias or maybe some procedures at the hiatus in the upper abdomen, like hiatus hernia and all. But for common groin hernia, I don't think robotics are justified as far as their cost is concerned, and also the advantages. In robotics, if you know, Dr. Naidu, the port size is 8 millimeter, all port size, instrument port size. And the camera port size is also bigger than the laparoscopic. So, and if you if you ask me honestly, robotic surgery per se, globally, if you see whatever studies have been done in US, it has not shown improve when they were compared with laparoscopic procedures, not shown significant outcome difference, advantages for the patient. Yes, robotics is good for surgeon because surgeon is less stressed. He's sitting on a console and operating it. So I think there are certain procedures which are justified, like radical prostatectomy and some other procedures, urologic procedures, and some complex hernias. But otherwise, common groin hernia, the standard TEP and TAP laparoscopically are quite good.
Thank you, sir. Thank you.
Dr. Misra, I have a question.
Yes, sir.
Chong.
Yes. I just had a patient who went for robotic surgery, but his was a very complex hernia because on the left he had 2 recurrent hernias, and on the right it was also a recurrent hernia. And he also had a laparotomy when he was a child at 5 years old because there's a very strong family history of renal stones. And he had Steckhorn calculus before and so on. So when they went in, they needed the robotic surgery because the whole area was all fibrous and scarred and very, very difficult surgery. Your comments?
This is basically, if you have a robot, you will say, I'll do robotically. You could have done the same thing laparoscopically also. After all, when you use robotics, is for you, not for the patient. You have to make that dissection in that fibrous area by laparoscopically only. By using robotic is only a tool to facilitate that. If you are going to take longer, suppose this complex hernia, you are going to take 3 hours to operate, not 1 hour, then it gives you the comfort sitting on the console, but your assistants are by the side of the patients. They are handling the instruments, because robotic that does not provide you with all the instruments actually. So this is a actually misconception that robotics helps in surgery. Yes, if you need suturing sometimes, robotics does help. Wherever you need suturing, then robotics is a good for suturing. But nowadays, young surgeons, they are all trained in suturing also laparoscopically. And I can remember one French surgeon who was doing laparoscopic radical prostatectomy at Mount Sinai or Memorial Sloan Kettering Hospital. So I asked him, they had a robotic standing there. So I said, why don't you use robot to do radical prostatectomy? He said, you saw me doing, I don't need robotic. So anyway, that's many surgeons cannot learn laparoscopy, so they move directly to the robotics. That is also the fact. And robotics, if you remember, in US, the Da Vinci company pushed gynecologists to take robotic surgery for hysterectomies without properly undergoing training. And there were, at one point of time, there were 300 litigations going on for complications. So any surgery, whether you do robotics or you do laparoscopically, you have to be well trained, and you have to have a mentor and mentee, undergo the training for those skills. You can do, if you have the machine, somebody is paying for it. Yes, you can do robotically, but I don't see that robotic per se will take away those the adhesions or more complexity that can be dealt with laparoscopic also. But so it's a tool which we should use for our advantage. But what I'm saying, doing cholecystectomy, doing common groin hernia with robotics is just a commercial hype, marketing gimmick, I call it many a times. So it does not help the patient. It does not improve the outcome. It increases the cost of care.
Agree. I totally agree, because I was a bit shocked when they decided to use a robot for that surgery. So yeah, thank you very much. You've given us a very concise and very clear and very honest opinion. Honest opinion about robotic versus laparoscope. Thank you very much.
And sometimes I went and saw some of my colleagues now doing robotically. I thought I can do a better job laparoscopically. So it's not that robotics is always good, and it definitely helps us. If I'm doing a 6-hour procedure, it helps me. I'm sitting and I'm not stressing. I'm not using my arms. But common procedures where you are not needing very suturing, laparoscopy is as good.
Thank you. Thank you very much, Dr. Misra. Thank you.
Thank you.
Most kind of you. Thank you.
Thank you.
So do we have more questions on the floor? Dr. Monica, do you want to say something on the topic?
Thank you so much. I always love to hear a great presentation by somebody who is well versed in the topic and an experience. It's always nice to always go back to the basics and understand how we learn medicine and how we should always continuously learn no matter where we are in our career. And I appreciate everything you just had in terms of the conversation that you contributed with Dr. Chan. So thank you for a great presentation.
Thank you. Thank you, Dr. Monica.
Yeah.
Yes.
Saurabh, if there are no more questions, I'd like to thank Dr.
I just
Mishra.
I just want to take one question where I think this is more of a patient or a general public question, where what is the early sign symptoms people should watch before they should go and consult a doctor?
For hernia, generally this is, I would say, male-female ratio is almost 30:1. So groin hernia is far more common in men than in women. It does happen in women also. So any swelling low down in the abdomen, what I say, when abdomen is joining the thighs. So on medial aspect, because it comes through the same canal which through which our testicular vessels and vas deferens travels. So the groin hernia actually projects outside through those opening. The ventral hernia, of course, is around umbilicus, primary ventral hernia. Incisional hernia is wherever there is an incision, if it has not healed properly, the deep layers, the fascia, the hernia can form. Then there are internal herniations, which sometimes present as an emergency because they were not diagnosed. Basically the paracecal hernias, paraduodenal hernias, the spigelian hernia, all these hernias. So these are uncommon hernias. So common hernias are groin hernia and occasionally femoral hernia, which is a little bit more common in women. So again, swelling at the junction of where our abdomen meets the thigh. So one should look for, and sometimes people do complain of pain. To begin with, the most hernias are not painful, but swelling will come. Sometimes it can lead to emergency because the contents which come down, they don't go back, and particularly in very young children, or if the hernia neck is very narrow, then chances of obstruction, strangulation are there. So treatment of any hernia is surgery. It's not medical treatment for hernia surgery. You cannot prevent groin hernia from forming. And whenever it is diagnosed, sooner one gets operation, better it is, because the repair is more effective. Recurrence rates are very low these days. With Laparo endoscopy, the recurrence rates have gone down to less than 1%. So it's a very safe operation today and very good results. The incidence of chronic groin pain has come down, which is there after groin hernia operation. So I think the symptoms largely is a swelling, what we call inguino-scrotal swelling. Inguino-scrotal swelling in men, and in women, it's a labia. It goes towards labia, and we do operate women also, but it's far less in women than in men.
And what about life post the surgery? Is that normal?
Yeah, I think what we say, at least we give 2 weeks for tissues to heal for the primary healing, and then naturally healing keeps taking place the whole of our lives whenever there is a scar on the body or incision on the body. But I generally ask the patient to take it easy for 2 weeks. They can work from home if they are IT professionals. Those who can work from home, they can work from the same day. We discharge them the next day, or sometimes people do even in daycare. So you don't need too much hospitalization, and you can be discharged the next day after when recovery is taking place, and call them after a week just for first review and give some pain medication. And most of the times there are not many issues. Occasionally infection issue comes up because there is a mesh can get infection, but incidence of that also has come down significantly with these laparoscopic repairs as compared to open repair. So hernia surgery is considered a clean operation. We do use 1 dose of antibiotics around when we do this operation. And most of the times, unless somebody has had diabetes or some comorbidity, then only infection is an issue. Otherwise, the infection rates, recurrence rates, chronic groin pain rates have really come down significantly following laparoscopic repairs.
Right. So I think Dr. Chong, we can get the session over. We have time. So please go ahead.
Dr. Misra, thank you very much for your wonderful
Thank
presentation
you, Dr. Cho,
on
and
hernias.
wonderful. Your question was very good for the audience. So
Yes.
thank you.
Thank you very much for your kind for your time to come and present to us. We really enjoyed it and we learned quite a lot from you. We hope to see you next time for another presentation.
Yes.
So
Thank
with
you.
this, close the session. Thank you so much for joining in. We'll see you again.
Thank you, Saurabh, and thank you, Nishita, for
Thank you.
coordinating.
Thank you.
Okay, we can leave.
Excellent.